All right, so today we're going to be talking about bacterial meningitis. First thing we want to go through for bacterial meningitis is what is your typical presentation of bacterial meningitis? And I think, classically we get taught that the presentation of bacterial meningitis is going to be all patients are going to have meningismus, all patients are going to have signs of meningeal irritation. And, truthfully, that's not always present. Those were really studies from a long time ago, and people usually don't present that late with bacterial meningitis anymore. So bacterial meningitis, you really want to have a pretty low threshold to treat. So you want a diagnostic system that is pretty sensitive. So the one that I use, the one that's kind of borne out in the literature, is patients should have really 2 out of 4 of these manifestations for consideration of treatment of bacterial meningitis. And the manifestations are going to be fever, 1, severe headache, altered mental status, and lastly, meningeal stiffness, so stiff neck. All right, so 95% of patients will have 2 out of 4 of these. They do have 2 out of 4 of these, or if you have a clinical suspicion for other reasons, you should really think about treatment of bacterial meningitis. Things like Burdinsky signs, things like Koenig signs are specific but relatively insensitive. There is one sign, and this is called jolt accentuation. Basically, you have the patient shake their head back and forth pretty quickly and see if that has worsening of their headache. Now, this is very sensitive in at least one study, but if you think about headaches in general, most headaches are going to get worse when you shake your head back and forth. So it has high sensitivity, which means if it's not present, maybe you can decrease your suspicion of meningitis, bacterial meningitis, but relatively specific. Obviously, a lot of the manifestations of bacterial meningitis were overlapped with manifestations of really any cause of meningeal irritation. So still on your differential diagnosis, this is going to be viral meningitis. It could be aseptic meningitis from other things other than viruses, things like sarcoidosis, autoimmune causes, other infectious causes like tick-borne disease, fungal TB, and especially if the patient has focal neurological deficits, really severe encephalopathy, seizures, you're going to be thinking about encephalitis as well. Sometimes they overlap. That's called meningoencephalitis. Sometimes it's very reasonable to treat for both of them at the same time. All right, so going over our bacteria that usually cause meningitis. So at least for community-acquired meningitis, these bacteria are really the bacteria that colonize your oral pharynx, right? So the first one that we'll talk about is going to be strep pneumo. Still the most common cause of oral pharynx. That's still really the most common cause of community-acquired bacterial meningitis is going to be strep pneumo. But other things that can also live in your oral pharynx is going to be your gram-negative coccibacilli as well. So gram-negative coccibacilli you might be thinking of in this case is especially if you have a younger patient, especially if they have a complement deficiency, you're going to be thinking about Neisseria meningitis, as well as actually H. flu too. All right, so community-acquired meningitis, we really need to think about covering all of these organisms, and the pathophysiology is that these organisms actually puncture probably into the pharynx, go up to the brain, and cause a CNS infection with meningitis. If the patient also has endocarditis too, you might even think about including staph on this as well. It's MRSA and MSSA. All right, so for community-acquired meningitis, things that we really always need to cover is going to be strep pneumo and your coccibacilli, like Neisseria meningitis and H. flu. The one medicine that can really cover both of these is going to be ceftriaxone. All right, so ceftriaxone will really cover all of these, and I think it's easy to remember this as you also use ceftriaxone for typical pneumonia, which is actually a lot of the same bugs. Similar pathophysiology, instead of those bugs penetrating into your CNS, they're actually microaspirated and go into your lungs. Also, similar bugs that actually end up calling otitis media as well. All right, so using ceftriaxone is good. Now, for community-acquired meningitis, you will always add on another medicine. And, it's probably not the worst thing you're covering MRSA, though it's not super common community-acquired meningitis unless they have endocarditis. but the vancomycin here is specifically added on for strep pneumo or ceftriaxone resistant strep pneumo. All right, so ceftriaxone and vancomycin is going to be your major coverage for people with community-acquired meningitis. The other ones that you do add on in specific situations, one, especially if the patient has GI illness like concomitant diarrhea, especially if the patient is old, so not even that old, age greater than 50, they consume alcohol, or if they're pregnant, you're going to actually add on ampicillin as well, and that ampicillin is going to cover your listeria. Remember, the lame mnemonic for cephalosporins, they don't cover listeria, they don't cover atypicals, they don't adequately cover aneurobes, they don't cover MRSA, they don't cover enterococci. So here, because they're not covering ceftriaxone and also vancomycin not covering listeria, you have to add on vancomycin. I will say, and now this may not be on Mixapp as much, but in certain cases, let's say the patient is immune compromised, or if they had a history of Pseudomonas, or if they're severely septic, you may want to switch that ceftriaxone and cefepime to also cover Pseudomonas. But your general go-to for treatment of community-acquired meningitis is going to be vancomycin and ceftriaxone, and empirically, because until you rule out causing strep pneumo, you're going to add on dexamethasone, which decreases morbidity and mortality and decreasing intracranial inflammation secondary to strep pneumo meningitis. All right, so that's going to be your empiric bacterial meningitis treatment chart. First, you'll start all this empirically, and then you're going to get the lumbar puncture. If you have to wait for the lumbar puncture, definitely start it earlier than later. And that kind of goes through other things that we look at for workup and diagnosis of meningitis, right? So you're going to start these, if you can't get a lumbar puncture quickly, you're going to start these empirically. And the things that you're going to be looking for on the lumbar puncture is going to be high opening pressure, high white count. The higher the white count, the more neutrophils, the more your suspicion, especially if that white count in the CSF is greater than 1,000. That really increases your suspicion of bacterial meningitis. High protein, viral meningitis, other causes of intracranial inflammation can cause a high protein as well, but if that protein is greater than 300, that really increases your suspicion. And last thing that is pretty relatively specific to bacterial meningitis, you can also see in fungal and TB, is that low glucose. All right. And every once in a while, you're going to need a CT scan before you get the lumbar puncture. I think it's better to memorize why we do a CT scan before a lumbar puncture, and that's the concern if there's a structural lesion that's increasing intracranial pressure, that when you do the lumbar puncture can lead to brain herniation. So these are really risk stratification to think the patient has a structural lesion. A lot of times people use the FAILS mnemonic. So F, focal neurological deficit. A is an altered mental status encephalopathy. I is immunosuppression. Immunosuppression like HIV or AIDS can put you at risk of things like toxoplasmosis, other structural lesions in the brain, nocardia as well. And then last you have L and S. L is lesions on the spine, or any history of intracranial lesions that puts you at risk for intracranial lesions. And then last is seizure, that also kind of puts you at risk for some sort of structural lesion, like a mass causing CNS irritability and altered electrical activity. All right, so that kind of goes through manifestations, diagnosis of community-acquired. Lastly is going to be hospital-acquired trauma, right? So patients in the OR, right? And what kind of OR, getting maybe a VP shunt or some type of intracranial surgery, and things that are present, unfortunately, in the hospital, in the OR. As much as we want to eradicate them, it's going to be MRSA. As well, the other thing that you're going to be concerned about here is going to be, oh, that was backwards. Sorry. Gram positives would be MRSA, and gram negatives that can be present in the OR, present in the hospital, is Pseudomonas. So if the patient has a hospital-acquired or traumatic, you really need to cover more broad spectrum. So with consideration of that, the medicines you're going to use in patients that are hospital-acquired is going to be vancomycin, which is going to cover your MRSA and strep pneumo. And the other one that in these cases you're always going to need to cover is going to be using cefepime to cover a lot of your coccibacilli, but specifically other gram-negatives, as well as pseudomonas. I think you can also use meropenem here. Our hospital system usually use cefepime just due to our antibiogram. All right, so that's kind of your manifestations, diagnosis, and workup for bacterial meningitis. Now, like I said, a lot of things can present like bacterial meningitis, viral meningitis, tick-borne disease, fungal meningitis, as well as TB meningitis. But if you do have a suspicion for meningeal irritation, it's very reasonable to start off with empiric coverage for bacterial meningitis. Get the LP, do a CT scan before if you're worried about intracranial lesions, and then you can use the LP to see kind of, is there, lastly, is there increased opening pressure, increased bite count, increased protein, increased glucose, and usually cultures and stains are about 80% sensitive. But if you really don't have any of those, if it's lymphocytic predominant, you might be thinking more of aseptic meningitis, and you can actually kind of de-escalate your antibiotics. All right, so that's our workup and manifestations of bacterial meningitis. Lastly, for treatment for patients with community-acquired meningitis, ceftriaxone and vancomycin is going to be your workhorses. Add on ampicillin, grade greater than 50, alcohol use, pregnant, immune compromised. Add on cefepime if they're immune compromised, severely septic. And for hospital-acquired or trauma, vancomycin and cefepime, you won't as much need the dexamethasone, and you really won't need Listeria coverage for that because it's not really prevalent as much in the OR.